Going live. Wow.
Here we are. Exciting.
Going live.
Oh, it was just like a little feedback because it's lagging sometimes, but
No worries.
yeah. So we can give it like a few minutes. Let the people hop on. I'll put it on our story real quick too. But while we're waiting, did you go to work today? Like, what did you do today? Like, did you have a good day?
I did. I did have a good day. What did I do today? So wait, we're live right now?
Yeah.
Oh, whoa. What did I do? So I decided I'm going into a field. I guess I'll talk about it later. But I'm on a consult service. So medicine, you have when you get admitted to the hospital or you see a doctor, you typically see the ER doctor, and then the ER doctor decides where you go, and you usually go to a team. That team typically practices a general type of medicine. So whether that's like general medicine, general pediatrics, general like hematology, oncology, they kind of handle what's in their realm. And then when their kind of stories get complicated, they reach out to consultants. So the consultants would be somebody like a pulmonologist, a cardiologist, a gastroenterologist, basically stuff like that. So so I'm on the pulmonology service, and so I was going around the hospital dealing with people with lung problems or problems that the primary care team thought there was situated in the lungs. And what did I see today? I saw some cool cases. I saw a person that had a chronic cough, and she recently had her right upper lobe taken out by a cardiothoracic surgeon because they saw a little nodule. She has a condition called rheumatoid arthritis. And so they took out the top of her lung. And so now she has this cough. And this happened just a few weeks ago. But it kind of makes sense, right? You take out a part of somebody's lung, you're going to expect them to cough, right?
Right.
That makes total sense. But the team was still concerned, wanted to make sure that she got good enough attention. So we went over, and she looked really good to us, and we kind of gave some general recommendations. She could get on like an inhaler. It was great. It was a good time. So eventually we were done with her, then we went to another consult. Some of our consults are patients who are intubated, meaning they have a tube in their windpipe called the trachea. And that tube is connected to a big machine that inserts air and takes air out, obviously to ventilate their lungs because they're not able to, or we make it so they're not able to. So we like sedate them. So that's what I did today. What did you do today?
Well, first off, that sounds like a crazy kind of hectic day.
Oh yeah.
So you probably are like exhausted, honestly, but
No, actually it wasn't that bad. It wasn't that bad.
really?
No, I'll get into what an inpatient service is. That's tiring. What I'm talking about right now, this is not tiring as much as you think it is. There's like real tiring stuff. Yeah.
Yeah, it just sounds like wow, it's exhausting. Well, I went to a lab today. I did a colony PCR. I isolated E. coli DNA. That was
colony PCR.
Yeah.
What is that?
So we grew colonies with our new DNA construct. So we like altered the genes. And so what we did was we were picking the colonies off of the plate and putting them in a growth serum, and then we run a PCR on it, and then we do a gel electrophoresis to see if the new DNA took or if it's still the old DNA, if it's still the old colony. So that's what I did today. But it did take, so that was good. We were all so happy. But yeah, that was fun. But I think we should go ahead and get started. So welcome everyone to the very first session for summer. If you guys have any questions throughout this, just drop them in the chat and we can answer them as we go or during the little question break. This is a really good time to ask about, medical school, about extracurriculars, about any of that kind of stuff. So this is like your guys' time to get advice. As for Shadowing, all you guys have to do is watch this entire session, and then submit a 4 to 5 sentence summary to our email, and then we will verify that and send you guys a certificate. If you guys need more details, please go to our Instagram and you can click the link in our bio, and we have all the criteria for our summaries. And without further ado, I will let you introduce yourself and you guys can start it.
Sure. Hey, everybody. My name is Jeremy Grossman. I am a resident physician in the fields of internal medicine and pediatric. So meaning I work with adults and kids. I'll get into where I am in my path, but I want to just first say I'd like to make today's session about you guys, less about me. I'll talk about myself a little bit, but ultimately it's to give you guys an idea about what your future might look like or different pathways you can go down to get to where I'm at or to around where I'm at. I want to build expectations for what you guys should be expecting in terms of the length of your careers, the time commitments, and kind of how your kind of psyche is going to be affected, how your personal life might be affected. But ultimately, I have to say before I start, it's been a really positive experience. I really enjoyed, being a physician, but it's a lot of hard work. So kind of to start from the top, I grew up in Southern California, in a place called Orange County. I went to high school there, and then I went to college at the University of California, Irvine, and I got a degree in biology. And during that time, I thought I was going to be a psychologist, so I also got a degree in psychology. That, I guess, never ended up, amounting to anything. But nonetheless, there was a lot of good knowledge about psychology, which you can definitely apply to medicine. So I did that. And then I figured out I did want to actually go into medicine. And I was super bummed because I was like, oh, why am I interested in this field? This is going to take so long to get into, so much work. I just want to like do something that's chill and make money. So ultimately I did decide to do it, to go through with it. I took a year off and I took the MCATs, which is like the SATs for medical school. And then during that year off, I also did some tutoring for money. I did a little bit of research, build that resume, and eventually got into a medical school process where I was applying to multiple locations. So I tell everybody apply to the top 3 med schools: US med schools, USDO schools, and international schools. Okay. You should apply to all 3. Unless you're like the smartest person in the world, you should apply to all 3 institutions. I know plenty of people that went to the Caribbean, for example, as an international medical school and are doing great and are better doctors than a lot of US doctors, trained doctors I know. Mm-hmm. I know a lot of DOs that are a lot better doctors than any US MD doctors that I know. So it doesn't matter where you go to school. It just matters that you get in so that you can get to the point in your career where you want to go. At the end of the day, we're all doctors. We all care about our patients. We all want the best for our patients and for each other. And ultimately, we're all living in a collegiate sort of field, and hopefully we can all get along and respect each other. So I applied to all these places, but this one school in Israel called the Sackler School of Medicine at Tel Aviv University, they reached out to me and said they had a position open for this month, meaning they had an open spot this year. And I was like, whoa, that's crazy. Yeah, I'll do it. So within a few weeks, I went off to Israel and I did medical school there. So in medical school, I did all the classic things. So your first 2 years are typically in classroom learning. Yeah. So a lot of like reiteration of what you learned in your pre-med studies, plus a little bit more, like anatomy, like, working with dead bodies and understanding the anatomy of patients. And then you also get the last 2 years of training, which is more clinical. So you're in the hospital, you're kind of working kind of as a pseudo doctor underneath residents and attendings, and you're kind of learning how the system works and how to apply all that knowledge. So I did that. And then throughout the time in medical school, I started an organization called the Homeless Project. And we essentially went out in the city, fed the homeless, surveyed them, gave them water, gave them resources. It was a really awesome experience, not only for myself, but I think I opened up a lot of people's minds to just general humanity. I think a lot of us say, oh yeah, I want to help everyone. But when it comes down to it, the last time you walked by a homeless person on the street, did you give them money? Are you really, a humane person? You really have to think about it, because being a doctor doesn't make you a good person. It's being a good person comes before being a doctor, at least in my view, or being a good person to others. So that was a great organization. I eventually, so the whole time I thought I was going to apply to family medicine. And family medicine is like really an outpatient field, meaning it's outside the hospital in clinics. You're dealing with a lot of general medicine of adults, kids, and then some like pregnant women's health sort of things. So I did that. And then I realized I didn't want to do it after I did a rotation. And I heard about this field called Med Peds. So that's what I do. It's basically a combined residency that combines both internal medicine and pediatrics, so adult patients and kid patients. But more importantly, it's basically like I like to call it family medicine on steroids, because you get all the outpatient training, but you get all the inpatient training too, meaning I work in every ICU in the hospital. I work basically on every floor in the hospital. I work in the ER. I work in every clinic. I work with all the specialists. I do everything. I learn how to be kind of a doctor of any field. And coming out of the residency, I can go into basically any specialty I want to go into. I can do general medicine for adults and kids and work in an ICU, do all this stuff, or I can specialize. So I've actually decided that I do want to specialize in what's called pulmonary medicine, so lung medicine, and critical care, so ICU medicine. So I'm going to be working as a critical care ICU doctor who also deals with the lung as an organ and how to best optimize it and treat it. So I've decided on that recently in the last like maybe 5 or 6 months. So I'm going down that path. I just started my 3rd year of residency. So I've got 1 more after this, and then I'll be, hopefully going off to fellowship if I get in, fingers crossed. So that's kind of where I'm at now. I'm doing quite a bit of research. I'm doing these sort of sessions. I just want to put it out there that I have an Instagram, Jeremy Grossman _. And so you guys can message me about anything healthcare career related. I can't answer medical questions because obviously that's a legal issue, but I'm not Brad Pitt, so I don't have like 1,000 messages. I'm never going to get to you. I'll get the messages and I'll respond to your messages. So if you have a question, even right now, shoot me it before you forget, because I'll be able to answer it. So you can follow me on there. You can message me, whatever you want to do, use me as a resource. So yeah, that's kind of my backstory. I live out in Long Island right now. I go to a residency out here at Stony Brook Hospital, Stony Brook University in New York. And I'm in my studio apartment now with my dog Zeus over there. If you hear him, he's a 100-pound American bull making a lot of noise. So if you hear him,
yeah, I did.
Did you hear him already?
Yeah, I did earlier.
There you go. Yeah. So maybe I'll at the end I can show you Zeus. He's looking over right now. Like he thinks I'm talking to him this whole time. All right. So that is the dealio. So I'd like to take your guys' questions if you have any. Is there a way for them to ask us questions?
Yeah. So we have a chat. So
you have a chat? Okay.
Yeah, live chat. So I have one for you actually. So
okay. I'm listening.
Oh, do you feel like
hold on. Someone's burning in here. What's going on?
Oh no.
Hold it. What in the world? Someone's burning. Let's see. Interesting. Maybe I'm just like hearing things or smelling things. Okay, go ahead. Yeah, I'm just like, I smell burning in here. Go ahead. Who's up first?
So do you feel like having this dual residency program was it easier for you to like get into a fellowship program since you're like experienced in 2 different fields instead of just one? Do you think it increased your chances of getting into the fellowship that you wanted, or like applying? Do you feel like
applying? Yeah. I don't know if it'll help, but I think it won't hurt. Pediatrics doesn't really apply to adult pulmonary and critical care medicine. It's kind of a separate thing. I think before, so if you kind of take it back, like in undergrad, I thought I wanted to be a psychologist. I thought I wanted to be a doctor. So I ended up doing both. In residency now, I thought I wanted to be an adult and pediatric doctor. It turns out I probably mostly want to be an adult doctor. And now in fellowship, I'm going to be doing lung medicine and ICU medicine. So I clearly have an issue with choosing between things. So I think it really came down to that. And that's just because I love learning and I love putting cool info into my head. But ultimately, do I think it's going to help? I really just don't think it won't hurt.
Right.
But what's important to realize is for everyone at your, I imagine everyone listening to this, or most people listening to this, are at a stage in their life that they're in college right now, or maybe they're in
Like high school.
like high school, right? So that being said, you really have to think about at this point is the time commitment that you're going to make, right? So let's say you want to do the thing that's like the least amount of time. So let's say you're a senior in high school, okay? 4 years of college, unless you're doing like a combined program like Karen is, most people are going to be going into a 4-year college, 4 years of medical school, and then a residency. The shortest amount of time a residency can be is 3 years, at least as far as I know. I don't think that there's a shorter residency option. So that being said, you're already committing as a doctor, if you want to be a doctor, to at least 11 years. Okay, after high school, that's 11 years. Okay, that's a big number. And I don't want to scare you. I just want you to realize how much time you're going to be putting in already. Now, let's say you want to be a neurosurgeon. Then you're looking at, I think it's a 6-year program. So that's like another 3 years. So you're looking at 14 years. And then if you want to specialize at a neurosurgery, that's another 2 years. Okay, so you're looking at like 15, 16 years if you want to be a neurosurgeon, right? If you want to be a general surgeon, that's closer to 14 years, 15 years. So you're going to be getting out, if you kind of go along the normal path, in your 30s, right? In your mid 30s, early to mid 30s, depending on what you want to do. So you really have to think about, what kind of doctor do I want to be? How do you figure out what kind of doctor you want to be? You shadow now. Okay, COVID has been a tough time. These programs like Club Med have been great, obviously, to account for that. But ultimately, clinics and hospitals are going to start opening their doors back up to med students. So I really, to shadowers. So I really encourage you to reach out. And I always tell people the best way to do it is just to call the clinic, say, hi, my name's so-and-so. I'm interested in shadowing this doctor because they are this type of doctor. Is the office open? 99% of the time, they're going to say no, but there's going to be that 1% that's going to say, yes, you can shadow me. That's going to be your best bet. There's a lot of pre-organized programs that you can join, but I don't really recommend those. I had a personally bad experience where I ended up just passing out water and towels to everyone in the hospital, which was just like not a good experience. So in my view, it's really important to create your shadowing experience. And all doctors have been taught. They had to go through school. So they understand the importance of school and teaching, and most of them are open to teaching. Now, why do most of them deny you? It might be situational. It might be because they're moving around locations too much. I don't know what it is, but most of them will deny you. So you just have to call. If you haven't called 10 or 20 people, then you haven't called enough people. Right. That's very important. Okay. Okay. You got any questions in the chat?
Tons.
Tons of questions?
Yes.
Oh my God.
I saw one that has like a lot of like arrows pointing towards it. So
okay. A lot of arrows. Okay.
Yeah. How does medical school / residency affect your relationship with others? And how does it affect your relationship with yourself? So maybe like mental health, like deep. Emotional. Yes. We get deep in these sessions.
Yeah. I think medical school makes you a lot tougher than maybe sometimes you want to be. But it's an important kind of defense tactic to dealing with the types of emotions that you deal with day to day. I've definitely become jaded to a certain degree. I still see my patient as a human in front of me, and I treat them with respect. But at the same time, going through what they're going through, I've heard a variation of many times before. So it's very easy to be sympathetic, but to be empathetic can be very difficult. So that's what changes. And I don't know if the level of empathy loss that I've had is in relation to my own personality or my journey or being in medicine. I don't know. But I think it's important to always step back and take a perspective. When you're having those tough days that you're not able to really empathize with your patient, take a deep breath and say, this is a person who's really suffering. You need to just swallow your pride right now and listen to them, hear them out, and try to address their concerns. So I don't think being a doctor takes being like having a rocket surgery type of brain. That's a joke, rocket surgery. I know that doesn't exist. I don't know. Maybe there's a rocket surgeon out there.
Rocket scientist.
Yeah, rocket scientist. Yeah. Exactly. But ultimately, it's, where am I going with this? You do change quite a bit throughout the process, but I think it's positive, and I think it's, for the most people that I've met, it's in a way that makes you more of a successful physician. Relationships with friends, I think what happens is the people at the hospital, the people at your medical school, they become your closest friends because you're around them, studying them all the time. So you still have quite a bit of relationships and quite a bit of interaction with other people. I don't think you lose that. And I'm a very social person who craves like interaction with other people. So I think that's totally kept going down this path. I don't know. Did that answer that person's question? I don't know.
Yeah, I feel like that answered it. Do you think that the lack of, this is just like my personal, but do you think maybe the lack of empathy comes when you like start comparing like your worst cases to maybe something that might not be as bad, because you're listening to this patient and you're like, okay, so these symptoms aren't as severe as some of like the worst things you've heard. So maybe that's where it's like it's hard to be empathetic because you've seen worse. I don't know. That's just like how I think. I don't know. You know what I'm saying?
Yes, 100%. I think it's kind of like it's kind of in the same category. I think, again, you've seen similar to this before. You've heard worse before.
Yeah.
So you kind of get to a point where you're just like, all right. But you don't know what they're experiencing, and like the mind is such a powerful thing that anxiety, depression, fear, all these sorts of things are very real emotions, and people experience them in such a real way that you have to take them at their word. Even if you don't think that they're telling the truth, you have to pretty much try to take everyone at their word, because ultimately you're the last line of defense to help them in that situation.
Exactly.
So that's important to think of. What else? Anything else? Other questions?
Yes. What were some difficulties slash stressors working in peds, and how did you deal with them?
Difficulties and stressors. Well, these are all kids, right?
Mm-hmm.
So as a resident, you're really a learner. It's really an extension of medical school. It's just more hands-on learning.
Mm-hmm.
And as a med peds doc, I'm also working with adults. So using adults to learn, right? On one end, you have to take care of them because you're a resident, you're a doctor. But on the other hand, you're a learner too. So taking care of adults who are a little bit tougher, more resilient, stronger, using them as a learning device can be easier. But when you're dealing with a kid, you're dealing with such a fragile being that hasn't experienced the world. And you have to be really careful with every little move you make, because you don't want to traumatize them, make them hate doctors forever, make them sad, make them scared, because that's going to affect them for a very long time. I was actually diagnosed with type 1 diabetes when I was 12 years old. And I've been living with it for, I don't know, what's 29 minus 12? Very long time. Okay, you guys can do the math. And I had a great experience. But it was a lot of people poking me with needles, a lot of medications they were giving me when I first presented to the hospital very sick. So it could have gone a lot worse, right? But I had good doctors that took care of me, that kind of helped me deal through my emotions when I was scared of what was happening. And, it worked out, okay? But I can't say that's the same for every single case that comes in the hospital, right? Every kid's experience is different. So knowing that you can really impact a kid's life is scary. But the positive note of that is, as you go along in your career, as you see more and more, you realize the impact of each and every little action you have, and you realize you don't need to be stressed about every action you make, because you understand which actions that you're making on a day-to-day basis are really the impactful ones that you need to be more careful about. Mm-hmm. I guess that's how I'd answer that question. But I think that ultimately, whatever field you go into, that role of being a doctor, dealing with your empathy, dealing with taking care of that patient, the struggles, you're going to have struggles in every field. Each field definitely has its own struggle, its own kind of bread and butter struggle. But you get through it. And ultimately, at the end of the day, we're all doctors taking care of our patients. And I think you can have a positive experience out of any field you go into, even if it's pediatrics.
Yeah. So this question goes kind of back to undergrad. And They said, I'm currently studying for the MCAT. How would you recommend studying for this test so you can ace it the first time around? Also, what was your MCAT score? And of course, if you're not comfortable sharing, like,
What's my MCAT score?
you don't have to share that if you don't.
I won't share my MCAT score, not because I don't want to tell what it is, but because I don't want that to affect the way anyone else perceives themselves and perceives the ability for them to get into medical school.
Yeah, like it's like a comparison game. It's not.
Right. It's multifaceted. The way you get into medical school is not just based on an MCAT score. It's based on your GPA. It's based on your volunteer activities. Based on your letters of recommendation. It's based on your interviewing skills. It's based on so many things. Would I say that GPA and MCAT scores are probably up there at the top of the list? 100%. They are very important.
Mm-hmm.
I'll say that I had a decent MCAT score, not super great, not terrible, just decent, like basically good enough. And I took the old MCAT. And I also took a new MCAT, and the scores were roughly the same. So your guys' new MCAT, I don't know where the scores have fallen. I was actually the pilot year for your guys' 3-digit scoring system. Mm-hmm. So I don't know where it's gone from now. I don't know. So as far as studying for the MCAT, I did the Kaplan course. I was pretty happy with it. I think if I could go back in time to get a better score, I would have done the either in-person or live training. I think I just did the videos. And the problem with the videos is you kind of tune out, you like zone out, and you do it on your own time, and you can kind of lose track of what you're doing and the progress you're keeping up. And you don't get like one-on-one teaching, because there's so many times where you run into just like a hard spot where you just cannot figure out this concept. You just can't get this concept, as smart as you are. And by the time you go through college, most of us kind of get to that point where, okay, we can kind of like figure this out, troubleshoot it, and like get to an answer if we're trying to figure something out. But the MCAT's tough. There's a lot of components of it that are really tough. Like, for example, the English section I think is really difficult. I don't know how that's changed or how that's shifted, but oh my gosh, that was so difficult for me to like interpret what the author was trying to say. Like, I hate that. What I really like is just tell me what's going on. I'll tell you what's going on, and we'll do it. I don't want to hear like, well, the sky is blue, but is it blue?
I feel like a lot of health majors are like that. Like, it's cold, hard facts. Not a lot of there's not a lot of room for interpretation. Like, if someone has a symptom, they have a symptom. There's not like a
100%.
No, like if you have a burn, is it really a burn, or is it,
Right? Is it?
But yeah. Back to undergrad, what kind of clinical experiences did you guys see that question a few times?
Clinical experiences. So I want to say again, guys and gals, if you want good clinical experience, and if you're thinking about being a certain type of doctor, go on. It doesn't matter what type of doctor you shadow, at least in my opinion, you get into medical school. It just matters that you shadow a doctor. So if you're interested in neurosurgery, reach out to neurosurgeons locally. So go on Google, call their office, email their office, whatever it is, and say, hey, I'm interested in this. Is there any way I could shadow you just to see what it's like for a day? And a lot of them are going to say no, but some of them or one of them is going to say yes, and you're going to go to that one. That's what I recommend for clinical experience. Hands down, I recommend nothing else. The preset programs, I think they're a hit or miss. Some are probably good, some are not so good. It's really important that you create your opportunities.
Yeah.
That's clinical. If you're talking about volunteer, I was in an academic fraternity. I was like a philanthropy chair, so I organized a lot of like charity events. What else did I do? I played guitar at my Sunday school for like 6 years as my work opportunity. What else did I do? What else did I do? I was doing research. To do research, again, I would just like talk to your professors, whoever your professors are, look them up, see if they're doing research, and just email them. Hey, professor, I'm in your class. Or, what can I help with? What research project are you doing? I would love to help. I'd love to get involved. Mm-hmm. That's what I would recommend doing. Create your opportunities, because that's been the best output for me. I don't know why. I'm just speaking about personal experience, but that's the best output.
Mm-hmm. Someone asked, I'm very interested in the pediatric field. How would you describe a typical day working in the internal med/ped?
Okay, so internal medicine peds, for those of you who might have just logged on, is combined. So it's adult medicine and pediatric medicine. So half the time Every 3 months, I go back and forth between adults and kids, adults and kids. So if you want to just speak about pediatrics, I'm happy to do that. The question is, what's it like to be in pediatrics?
Yeah, it's like, what's your typical day like working with like pediatrics?
Typical day. This is actually a really good question. So I'll talk about the hospital. So in clinic, in your outpatient setting, you usually go in and every 30 minutes you see a different patient who could see anything under the sun. Okay. From well child checks to immunizations to sick visits to people with coughs to people with headaches to people with abdominal pain, whatever. You'll see all of that. That's kind of like the ER too. When you get to the hospital, your day as a resident is what I'll talk about because I think that's what you guys are closest to. In the morning, you get up. I get up around 5 and I walk my dog Zeus, who moved now, is now at my feet. And I walk him in the morning. I brush my teeth. I have a coffee, and then I drive to work. So I'm at work by 7 o'clock. I go up to the sign-out room, which is where the night doctor tells me about my patients' events that happened overnight, right? Because there needs to be a doctor there at all times. Even when patients are sleeping, there's still emergencies, right? So you need to have a doctor there. So that doctor tells me, Mr. Johnson did this, Mrs. blah, blah, blah did this, Mr. Chloe did this, he needed an x-ray, I gave this guy Tylenol, whatever. Gives me the whole list. I say, okay. Then it's my turn. I take over, I send that gal or guy home, and it's my turn to be the doctor. So I go around and I visit all my patients. I typically have, as a senior resident, which is what I am, I have 15 to 20 patients, okay, depending on the day. And the interns typically have anywhere from like 7 to 8 patients, okay? So I'm supervising them, watching their patients, and I'm also watching the same patients, and maybe I'm watching another set of patients as well. So there's a lot of patients.
Right. Sounds like there's a lot to handle.
But you learn as you go on how to manage them. You know which ones are emergencies, which ones aren't. You don't need to be holding all of their hands all day. There's really usually only 1 or 2 really active patients that you need to be paying attention to. And if they're too active, they go to an ICU where they can get way more attention. And if I'm an ICU doc, maybe I'm seeing like 10 patients, 15 patients a day, and I'm sharing those 10 or 15 patients with like 3 other doctors. So it's like you have a lot of help because those patients need a lot of support.
Okay.
Okay, so that happens. I get signed out. I see my patients. My interns see their patients, and then we do physical exams. We talk about the plan for the day. We prescribe them certain medications that we think they need. We get lab values. We look at their chemistry and their complete blood counts, their coagulation factors. We look at any cultures. We look at any x-rays maybe we took overnight. And then the attending physician comes. The attending physician is like the head honcho. He's kind of the supervising, or she is the kind of the supervising physician who at the end of the day, like makes all the calls. So even though I and my interns say, this is the plan, the attending physician will say, okay, I like this, I like this, I like this, but this last part of the plan I wouldn't do. We're gonna take that out and I wanna do this instead. So we go, okay, you're the boss, let me make it happen. And through that process, we're taking care of patients, but we're also learning ourselves how to treat patients. And each attending, one attending might say, let's do this, but another attending might say, let's do this. So you learn different kind of treatment and management tactics from different attendings. And by the end of your 3 or 4 years of residency, or 5 years or 6 years, if you're a neurosurgeon, you say, this is the type of doctor I'm going to be. This is how I'm going to treat my patients. And this is how I'm going to be going forward as my own attending physician. So we deal with our patients during the day. We write some notes on our patients, a lot of documentation. And then in the afternoon, maybe we're responding to emergencies. Maybe we're getting new patients from the ER. They're calling us saying, we have a patient for your service. We want to transfer to you. We go, okay. We see the patient. We transfer to us. And then at 7 p.m., the night doctor comes back. I give him or her my patients, say, have a good night. I'm going to go to sleep. And we just repeat the cycle again. And that's an inpatient service. That's kind of how it goes. If you're on a consult service, all you're really doing is just responding to certain questions by the general inpatient service team. So if I'm a pulmonologist, a lung specialist, they're going to call me for lung questions, and I'm going to go see the patient and give them recommendations. But that schedule is nice. It's like 8 to 5. I don't have to be there like 12, 14-hour days like I do on the inpatient service.
Mm-hmm.
Right.
So going off of that, someone asked, was it something about peds that made you want to switch out to adult only? Because like you talked about doing your fellowship in like adult pulmonology and stuff like that. So was it something particular about peds that made you want to turn away, or like what experience did you have that made you go more towards adults over kids?
This is a really good question. Whoever asked that question, good question. I've been struggling with this, right? Because I've done this twice now. I keep picking these double majors or double specialties or double careers because I can't decide and I want to do both. But ultimately, I fall in love with one or the other and end up going into it. What do I like about adults? Adults have a lot more problems. Okay, so you have to think about interactions of different medications and lab values and interactions of different diseases and their home status and can they walk and all these different sorts of things. And there's just more thinking involved with adults, at least in the general medicine world. In pediatrics, there's a lot of thinking, but the diseases you see in pediatrics are just not the same as adults. It's a whole nother ballgame. And it's not to say that pediatricians aren't smart, because they are very intelligent, extremely intelligent people. But it's a different type of medicine in the sense that the things and the actions and the thought process that you're going through on a day-to-day basis are just different. And there's more thinking, there's more procedures. I love doing procedures, kind of procedures like mini surgeries, right? So like today, I put in a very special IV line. It's a long line that goes right here. And you can deliver special medication, which is kind of it's not a surgical procedure, but it's a minor procedure that I use an ultrasound machine and I guide a wire through the vein. And if you want to look it up, it's called How to Insert a Midline Catheter. If you look it up on YouTube, there's a lot of it. It's a midline catheter. Another procedure I do is a paracentesis. You can look that up on YouTube. It's where somebody with liver failure or maybe kidney failure or heart failure come in and their belly is swollen with fluid and it's really hurting them. So I go in with a very special needle and I drain it. But I also use an ultrasound machine because I have to avoid any structures that are important and that can bleed and necrose in the stomach, or rather in the abdomen. So that's a fun procedure. What's another procedure? A lumbar puncture, where you go into the spinal canal of somebody, extract fluid to see if maybe there is a disease or if there is an infection. Very fun stuff. So I like procedures. What else? I like ventilators. I like sedation. So ventilators help people breathe. They're machines. What else do I like? Sedation, putting people to sleep. Not killing them, but just putting them to sleep and managing their bodies for them, acting kind of like their brain in a way, and really saving people from really horrific things that are happening. And but that goes to say too that you don't always save people in the ICU. A lot of people don't make it in the ICU, but you are the last straw before it's determined if they make it or they don't make it. And that comes with a lot of responsibility and a lot of emotions. So that empathy that I kind of was talking about losing is something that's normal and natural, but you want to try to hold on to that as much as you can, because you want to not only be there for your patients, but for your patients' families when they're going through a difficult time and they're losing a loved one. That's why a lot of family, or rather ICU doctors, go into what's called palliative care, which is end-of-life care planning for how to deal with end of life in terms of medication, in terms of management, comfort, where to send them when they're dying, a lot of, kind of tough things to deal with.
So going off of that a little bit, you said you have to hold on to empathy, you have to, relate to these patients, see them as people, but then you also have to hold like a balance where you don't get too involved and then take it like in your personal life and let it overwhelm you. I know like a lot of doctors I've talked to sometimes say like they struggle with, not getting too involved. So it's like, how do you hold a balance of caring just enough, but also not like allowing it to affect your mental health or your personal life? Because I know like sometimes it can
So to summarize, you're asking,
how do you find
in one sentence, how would you summarize that?
So in one sentence, it would be, how do you find the balance of caring just enough, but not too much?
Oh, I think that comes with time. That's a tough thing to say. It comes with time, and every doctor has their own style. So when I go into an inpatient room, I usually try to read the mood in the room, but I always, if I can, I go to a light, positive, jokey, kind of fun sort of atmosphere, because one, I want to enjoy my job, but more importantly, if a patient's smiling, they're having a good time, their family around them is having a good time, they think that I'm comfortable with their condition enough to make a joke, then they're going to feel better about what's going on. If the doctor's comfortable, then the patient should feel comfortable too, to a certain degree, right? Because then I would be worried. If I was worried, I'd be at the end of the bed like this, telling nurse, okay, do this, quick, check on that, intubate, right? So it's really important to show, one, confidence that you know what you're doing, and two, to also let them know when you don't know the answer and tell them that you'll find that answer, that they have faith in you, that you have enough self-confidence that you can say, I don't know the answer to that. Let me go find it out for you. And patients actually have a lot of respect for that. When you say, I don't know, your mind goes to, wow, the patient's going to think you're dumb. But a lot of the time, they really respect you more. Because ultimately, one, medicine's changing like crazy. I have new articles I have to read every day. If you think even after these 16 years, you're going to be done learning, think again. It's a lifelong learning. You're like going to be in school till you die or till you retire. There's really no end of learning medicine, because you want to do right by your patients. If you're practicing old medicine, then you're not practicing safe, good medicine that's going to be helping your patients to the maximum, capability, right? Mm-hmm. So keep that in mind. You're always going to be learning. So that being said, did I answer that question?
Yeah.
Kind of? Okay.
Yeah.
I'm off on tangents.
No, it's good. It's like we're getting like this awesome advice. Awesome.
Okay.
Another one, I think this is the last one here. But what extracurriculars do you recommend doing in high school or college to help our chances of getting into medical school?
High school, as far as medicine goes, I don't think you need to be doing anything medicine related unless you really want to be. When you're in high school, get good grades. See if, do a little extracurricular, whether that's sports, whether that's joining the band or the orchestra or like theater, I don't know. Something positive. And live your life. You're in high school, okay, guys? You gotta live your life at some point, because when you're gonna get to college, med school, residency, that's crazy. And then by that time, you're gonna have kids and a family maybe, and and a practice and maybe a business on the side. You're not gonna have that time. So if you want to, really my advice is to just enjoy high school and get good grades. That's it. Just two things: enjoy and get good grades. Okay. When you get to college, that's another story. The big things in college are, I think it's my three big things. I forget. Grades. Okay. Research and volunteer. Okay, grades, research, volunteer. You need those three components. And the grades component includes MCAT too. Okay, academics. And then with all of those things come letters, right? Letters of recommendation. So high school, enjoy. College, extracurriculars. Med school, pass. You know what they say? Have you guys heard of the equation in physics, P equals MD? Karen, have you heard of that one?
Yeah.
I don't even remember what that stands for. Something equals mass times density. What's P? Do you remember?
I think it's been a while.
It's been a while. But what I'm trying to say is there's a joke in med school that says P equals MD, meaning if you just pass medical school, you'll get an MD. The grades don't matter. You just have to pass. That's all it means. Okay? So those are kind of the steps you need to take. If I were all of you right now, everyone out there, any grade, wherever you are, if you want to really figure out if medicine's right for you, email or call a local doctor in the field that you think that you're interested in. You don't know what you're interested in, but you think you might be interested in it. Maybe you saw House and you want to be like an internal doctor. Maybe you saw Scrubs and you want to be a surgeon. I don't know. I don't know what you watch. But based on whatever your experience and your kind of like outlook on what medicine is, follow that doctor, shadow him for a few times, or her, figure out, is this something that I want to do? Because you don't want to be 15 years down the road graduating and thinking, I don't really like this. Why am I doing this? There's a lot of doctors that I know, or a decent amount, that are finishing this clinical residency and they're going out and going into business, which is fine. There's nothing wrong with that. But if I were them, I would have just done business,
Like 15 years ago. Yeah.
So you just think about what you want and figure out, try to jump forward and say, is this something that I want to be doing in the future? is this really something that I want to be doing? And it's hard to tell, but you do your best because it's a long time in the future to tell if this is something that you want to be doing.
So there is another question, and it's kind of like a loaded.
Ooh, load them up.
So, have you ever dealt with any difficult patients regarding racism or ethics, and how do you deal with it? Yeah, I said it was loaded.
It's loaded for sure. With racism. I think
sexism, honestly, where it's like,
No, I know what you're talking about. I'm trying to think of a specific example. The question is it racism towards the doctor or racism towards the patient? I assume it's towards the patient. I don't think I'm a racist, or rather, I don't treat my patients in a racially biased way. I treat all my patients as equally as I can. And all of us come into our lives and our jobs with biases. And those are not only centrally located around racism. That's might be centrally located on, oh, this patient's really annoying. I don't want to visit them more than once today. Oh, this patient smells bad. I can't go in that room again. That's too much poop. Or blah, blah, blah. But you got to think about it in terms of what's the medical diagnosis of this patient? Do they need my attention? Do they really need me to be there right now? And you kind of have to triage and say, okay, even though I don't want to talk to this patient, I need to be in this room. So that kind of goes into ethics now, right? The ethical thing to do is to treat all your patients equally, or as equally necessary as possible, right? If I have a patient that's actively having a stroke and I have a patient with a cough, yeah, I'm going to probably spend more time with my patient with a stroke. Okay, it's not about being equal in that sense. It's being equal in terms of how much energy you're giving patients based on their necessity for that attention, right? Mm-hmm. So that's something to keep in mind. There's like 4 parts to of like ethical components, and I'm forgetting them all. One of them is justice, meaning everything you do should be doing right by your patient in a just way. 2 is beneficence. You always want to be benefiting your patient, whatever you're doing. Non-maleficence, meaning nothing you do should cause more harm than it does benefit. Now, some things you do are going to cause harm, right? So that special IV I put in that patient might cause them a little pain, right? That's a little harm, but ultimately I'm going to be able to give the medications that person needs to survive through that vessel. So the benefits outweigh the risks, right? And then the last ethical component is autonomy, meaning if this patient has mental capacity, can this patient are we doing what this patient wants us to do? You'd be surprised. A lot of patients come into the hospital saying they want to do not resuscitate, meaning if they're dying, they don't want us to save them. They just want us to make them comfortable. Okay. So I recently read an article that says something in the range of 70 to 80% of deaths in a hospital are because the patient didn't want to be revived, meaning they were a DNR. So that gives you a big perspective that, one, we're doing a pretty good job as doctors because only 20% of these deaths are related to a patient dying, probably from a reason that we couldn't prevent and a component of medical error. Right. But a majority of them are because the patients decided the life I'm living with my current disease is just not worth it right now, and I'm suffering. And I think me being at peace and passing is going to be a more positive thing than for me to continue suffering just so that I can live on this planet.
Right.
So again, going back to what ICU medicine is, that's a lot of what ICU medicine is. It's asking people, you are very sick and you are on the brink of death. How has your life been before you came in today? How do you think it's going to be if we save you? And what do you want? Based on all that information, do you want to keep going forward living like this? Or do you want us to pull the plug and let you go peacefully? And it's not so simple like pulling the plug, but ultimately that's what you're dealing with. That's kind of the things that you're dealing with. And not only in an ICU are you dealing with that, but you're dealing with that in almost every part of the hospital. Right. So these are things you have to think about as a doctor. And, is this the field you want to go into? I don't know. But you guys have to determine that now. And you try to do it as early as possible because I don't want it to be too late for any of you to realize that this is not the field for you. And I will say with the caveat that NPs, PAs, nurses, techs, LPNs, LVN, everyone in the medical field, medical assistants, you all can live a positive life. And potentially you don't have to go down this huge path of being a doctor if all you want to do is ultrasound people. If you want to be the king or the queen of ultrasounding somebody, an ultrasound tech who goes to school for 2 years to learn how to do that is going to be way better than me. Can I ultrasound you? I can ultrasound you. Can I look at your heart? Yeah, I can look at your heart. But that tech can do it way better because they went to school for 2 years straight and just did ultrasound. Well, I took 15 years and learned everything about everything, right? So there's lots of fields of medicine. So you have to determine what you want out of it. Do you want procedures? Do you want to be in surgery? Do you want to be in the hospital? Do you want to be in the clinic? Do you want to be working 8 to 5? Do you want to be working 24 hours a day, 3 days a week? Like, do you want to be working shift work? Do you want to be working full day hours? Do you want to have a family? Like, what are your goals and what do you want out of life? Take a piece of paper, write it all down, figure out what you want. What do you want out of your life? You, your mom, your dad, your guardian, society might want you to be a doctor. But do you want to be a doctor? Is that what you really want to do? You have to figure that out. You have to ask yourself that, and you have to really break it down. Pros and cons it. Get a piece of paper out and pros and cons it. I'm preaching. I think I'm done preaching now.
No, that's such a good idea. I was literally thinking about where my pencil's at. No, honestly. But wow, thank you so much for sharing that. I'll do one last question before we can you can give us our what you think would be the best advice for everyone, wherever they are, and then we can just wrap up. But here's a question. Have you actually experienced a lot of death around your patients, and how does it affect you like mentally, and how do you cope with that? Like, how do you get over
it? Everyone deals with it differently. I think when I first started as an intern, I was very stressed and very emotional because I was dealing with all this new material, fast-paced, around all these people who I felt knew so much more than me, and I was so stressed out and hard on myself. So I was naturally on the brink of like crying at all times. I remember I had a death or two in intern year, and I shed a tear after because I was emotional and I felt pain, but I felt pain for myself. And since that time, I've kind of gotten more solid in kind of my psyche and my mental thinking and how I get through the day. And I've seen a lot by this point. I'm 3 years in now, and I've seen a lot. And I don't get shaken up by really anything anymore. It's rare when it happens, and I'm not saying that's a good thing, but it is what it is, right? So when I have a death, I would say most of the deaths that I know did not die suddenly. They died because they chose that they wanted to not be resuscitated prior to that. They died because they had a disease that they were living with for a very long time that they knew they could die at any moment. It was expected, at least from a medical perspective, right? The family might still have been affected, but it was expected. The other day, there was a patient that did die suddenly. So in the morning, they said on the loudspeaker, "Code blue, adult, come to this room right now. This patient passed out." So I ran down. Patient had passed out, and we shook the patient. They woke up. Said, "Okay, maybe it's vasovagal," meaning they just passed out because they got up too quickly or they got nervous, whatever it was. So that was nothing. This was like a 40, 50-year-old person, young person. A few hours later, code blue, same room, please come right now. So I went down. Patient was on the floor, and already people were doing chest compressions, trying to save this person's life. Their heart had stopped. And they were there in the heart unit, but they didn't have a severe, heart condition that was going to cause them to die in that moment. So it was sudden. So we were doing CPR on this person for maybe a half hour to an hour, and setting them up with this very special machine called an ECMO. It's called extracorporeal membrane oxygenation, meaning we were injecting oxygen with a machine directly into their body. So we were taking over for their lungs and directly giving them oxygen, and they still died. We couldn't get pulses. So this person died suddenly. and I didn't know this person. This was a person on the unit next to mine that I helped code with, but it was crazy at how quickly this person died. And it's usually those really quick deaths that get to me because I realized, wow, I'm kind of young. You know, this person wasn't, we didn't think was going to die at all. And something random out of the blue just happened and they died right in the hospital. And even with all these doctors and nurses and people around them, they still died. So it makes you think, you know, you get to a point like, wow, relating back to me, I could die at any moment. That's scary. That's so stressful. And, you know, you feel for these families and you feel for these patients. And
You truly are.
It's really scary. But ultimately, you kind of dust yourself off, you get up, and you kind of have to keep going because you got 15, 20 other patients that are waiting for you. And after so many times of that happening, you just kind of learn to deal with it. And that just becomes a part of who you are. And whether for good or for bad, it's what you kind of have to become to do best by all your patients. And you know, nobody said doctors were gods or God, and that's because they aren't. Because we can't save everybody. We can only save, you know, what modern technology says we can save and what we think we can save as doctors, and we try our best. And part of the job is knowing not everyone's going to make it, and it's tough after those episodes to not blame yourself. But you know, as a team, you are nurses, doctors, NPs, PAs, techs, attendings, fellows, all these people. And you come together at the end of it and you talk about it and you say, we're all in this together, we got this, and keep pushing forward. And you go to sleep and you wake up the next day and you do it all over again.
Oh, yeah. I mean, I feel like there's not much you can do except for trying to learn how to cope with it. But I can understand how like the realization of your own mortality can be like, you need a minute to like cope with that. Yeah.
It's weird. It's definitely weird.
Yeah. But thank you so much for answering that question. That was very loaded. But so just to wrap it up, what would be your biggest piece of advice for anyone watching this who might be considering med peds or like just considering becoming like a doctor in general?
I'm going to change your question slightly.
Okay, that's fine.
What advice would I give to just be a good person and live a happy life, at least in my view? I'm by no means an expert. I've given a lot of medical information references, and you guys can all, you know, I hope you all add me right now on Instagram and shoot me a question, because I'm sure you guys all have questions, and I will answer them tonight. If you send them right now, I'll answer them tonight. Don't be so hard on yourself. Society sets a lot of values on you, and it can be difficult. And you can either respond to those threats and those stressors, or you can process them and turn them into something positive and motivation for you to get to where you want to be. But at the end of the day, you have to be comfortable with who you are, confident with who you are, and understand that you're just a human. You're not perfect. And though today didn't go well, though the day before didn't go well, tomorrow's a new day, and you can do really anything you want to do as far as you think you can do. Mm-hmm. I recommend all of you to do a lot of soul searching beyond medical school app searching to figure out, one, is this the right career for you? Two, are you happy doing this type of thing? And three, if you want to be a doctor, you want to be a good person. Are you being that good person now? Are you making that positive difference in the world right now? When you walk by that homeless person on the street, are you giving them cash and giving them a smile, or giving them the cold shoulder and walking by, right? Mm-hmm. To be a good human, to be a good doctor, it really starts now. It doesn't start in 2 years when you get to med school, in 4 years when you get into residency, and another 4 years when you're a fellow, and another 5 years when you're attending, and another 10 years when you move to California and you have a mansion. It starts now. So be the positive change you want to be in the world. Make sure you do what you love doing and try to have fun doing it. and have fun.
Yeah.
That's pretty much it. Just stay positive. Have a good life.
Mm-hmm. Well, that was fantastic advice. Thank you so much. Just
Sure.
not just for sharing that, but like for everything you shared today. Definitely got everyone in this chat and like me as well, like thinking about like what do I really want? Maybe I should make a list. And so that was very insightful. Thank you so much. Lots of positive feedback. If someone said thank you for preaching because you're like, oh, I'm preaching, but they're like, thank you. But again, guys, if you have any questions, go to his Instagram, go give him a follow, DM him any questions. So that's awesome. Thank you so much for being like so willing to answer all these questions. But again, guys, the summaries, they're not due yet. They'll be due at the end of summer, so you guys have some time. But I would recommend getting those in as soon as possible, so you're not like putting it off for too long. Again, thank you so much for coming onto our program and sharing all your wonderful advice. And again, guys, follow the Instagram. And I will see you guys all again next week. Thank you, and good night, guys.